On the main stage, I will call to the main stage Dr. Carlos Frederico Pinto, and he will be supporting the session.
Hi there.
Hello.
How is the tide today? Great, huh?
Great, great.
Good to be
So
together.
I
So,
will leave you on the stage here.
yeah, I'll be presenting my close friend, Dr. Javier Sala, to discuss about. Uh, well, that's a big challenge. Is lean an answer to inflation? And so Javier is also a medical teacher. He's a great lean guy. He's doing an amazing job in Argentina. I had the chance to be there. So please, Javier, it's up to you now.
Thank you, Fred. Thank you, Fred. Thank you very much. It's a pleasure for me to be here. I'm wondering if you can see my slides.
Now we can. Yeah, good.
All right, sounds great. So did it advance?
Perfectly.
Okay, so it's a pleasure to be here, and I'm very, very happy to discuss this topic. It's a very interesting topic for us. We just, as an institution, we have 45 years old. We're located in the middle of Argentina, in Cordoba. We are a boutique hospital. We have 72 beds, and we have more than 8,000 admissions for the last 12 months. We received more than 82,000 ED visits in the last 1 month too. We're mainly, I would say, born cardiology, but now we have more than 53 specialties in our institution. So let's go directly to what we are suffering here in Argentina. What you can see here is that our inflation in the past September was 6.2%. That is 6.2% in 1 month. So compared to August 2022, we have 6.2% increase in just 30 days. From January through September, we had an accumulated inflation of 66.1%. The 12-month interannual variation by September was 83%, and the projected for this year is more than 100%. So how is that affecting actually healthcare? We can see here the sustainability index created by a private hospital association called ADECRA Sedim that it shows data starting from 2010 up to 2022. In green, you can see the cost index. In gray, you can see the bundle prices index. In yellow, the occupancy index. And in red, the sustainability index. And the dotted gray line is the point of equilibrium on average for healthcare private systems. So we can see that in the last 3 years, we've been going through really, really tough times. And not all of this is due to COVID. What we see even more challenging is the issue that it is not over, okay? And we can't stop the trend. So we're looking into a really bad scenario to come for our health system in the near future. So the C-suite, okay, started talking about this and how can we actually target this inflation? What can we do? So there's several options, that they started to discuss. One of them is, can we increase prices? Well, usually in our country, we're not the ones that are able to put the price. Usually the insurance and the payers actually do. What about increasing volume? What about reducing costs? What about being more efficient? And what about diversify? Okay, the way we actually spend our money actually and or deliver care. Or what about all of the above? So if you have to to have a choice, the best one is actually add value to our patients. And there's a very, very important reason for that. Okay, if we add value to our patients, we're mainly targeting all of them, and I'll show you why. This is actually George Merck. He's the son of the founder of Merck. He was the president of Merck from 1925 to through 1950, and then he was chair of the board for 7 years more. And he was already talking about innovation, teamwork, quality, efficiency, safety, social responsibility, more than 100 years ago. And there's a very important quote he had for his company. And it said, "We try to remember that medicine is for the patient. It is not for the profits. The profits follow. And if we have remembered that, they have never failed to appear. The better we have remembered it, the larger they have been." And we actually agree with that 100%. So I'm a cardiologist, like Fred said, and that's why here you have a stethoscope. And we're going to try to through this 20 minutes presentation, try to go through how we can improve. We have improved and added value to our patient through our appointment center. How we have also worked on making the reception of the patient more lean. How we have worked on our labs. We had 4 labs working in parallel, and we started working all together. How we worked on discharging our patients better. Okay, and that's usually a problem all over the world. We're always looking into improving discharge times, and how can we improve the patient experience on when they have a surgery procedure in our institution. So when we were looking at the appointment center, we wanted to improve efficiency. We started measuring performance. We observed the processes. We redesigned the layout. We standardized the appointment protocol. We empowered the frontline to do staff to demand, and we eliminated waiting time, stopped losing calls, and more. And what we did also was to add to in-person and phone calls other channels for them to be able to schedule their appointments. We went through web self-service and also email and also WhatsApp. And what we have, for example, here on the right side of the screen, we have there a timer that you can see how many patients are waiting, how many minutes are waiting for them, how many minutes do they have to wait to be attended. And then we have also how many FTEs are joined attending also other patients, and how many of them are also waiting. But this is actually located at the center of the room, so everybody in the front line can see this. So if they need to take a break and their patients waiting, okay, they wait until we have no patients waiting to take a break, for example. So our appointment center in 2016 and 2017 had a target that we needed to contact the patient once they called for the first time in more than 95%. So more than 95% of the patients that wanted to contact us, and we wanted them to be able to do it the first time. So if we agreed to reach that metric, we will we will put that in green. If we was 91 to 94% of all the calls answered in the first contact, it was going to be on yellow and then on red. We were able to achieve this. So in 2018 and 2022, we decided to raise the bar. So right now, our target is to be able to answer more than 98% of all the calls that are coming into the hospital. The major thing here is that, we don't know if that's an ambulance. We don't know if that's a heart attack. We don't want to lose any call. We want to be able to be reached by our patients. So let's look at our numbers, for example, these past weeks. And you can see here we have the day of the week, the service level, which is the percentage, and then the number of calls that came into that day. And we can see that close to 800 and also 600 calls can be answered without a problem, and we're reaching the target of 100% right now daily. What we also found out is that even though we added these different ways of contacting us and being able to schedule the appointment, they still want to talk to somebody. So you can see here is the way they connect with us. We have their WhatsApp in yellow, we have their self-service on green, but you can see that personal and also phone calls are the ones that are leading. So we still need to be very, very fast in being able to answer the phone and be able to hook to get the appointment for the patient. The other thing that we actually looked for was how can we improve the patient experience when they came to the hospital. So first was, can they reach the appointment fast? Can we actually book them as soon as they call? The second thing is that once they reach the hospital, can we see if they have a good experience? And what you can see here is all the different steps that a patient had to go through. If he had only 3 things to do, get an X-ray done, get an ultrasound, and then a cardiology consultation. And you can see that as soon as he walked in, he started looking into different areas that are almost doing the same thing. For example, here in yellow, you can see that they took many times, a number to be able to be called by a secretary, and then the secretary did the same thing. Show me your ID, show me your insurance company, and they went in the a computer and validated that practice. So we decided this is not adding value at all. The patient is actually going several times through the same process. He's waiting a lot of time in between, and that actually it should be changed. So we decided to change that, and we took all the different areas that were being reception, so imaging, the cardiology, everything that we could merge together. So not ICU, not the central lab, and there's a reason for that. There's a lot of patients that coming in the central lab all in 1 hour, but the rest of the hospital was centralized into the main entrance. And what you can see here in the main entrance to the left side is actually all the different boxes that we have to reception our patients. In this case, the patient walks in. What he does actually is get a number like he did before, and then he actually is able to go through one secretary and be able to schedule all the appointments in one time. So in order to speed up the process for that one-time secretary reception, we started working, employing a 5S, and also we wanted our secretaries to do the things the right way the first time. So we actually standardized every step they need to do to be able to not make mistakes, of course, and do it as fast as we can, and then sending the patient to get what he actually came for, the x-ray, the ultrasound, or actually the consultation. So this is how the actually patient journey looks like if they needed to do exactly the same thing that he did before. You can see that he walks in, he actually punched in his ID, and then he actually gets called by the secretary. Then he can go to the cashier only once, and then he goes through the hospital to get all the studies that he need to be done. And actually, it can be done. He can actually go through 2, 3, or even 10 studies without having to wait for another secretary again. So, what's this? What was the impact of this initiative that we have? Well, what you can see here in 2014 compared to 2018 are the secretary job positions. We were able to decrease that by 32%. The central reception jobs, okay, were decreased by 37%. The FTEs, okay, the number of secretaries that we had at our institution decreased by 13%, and the FTEs in the central reception decreased by 27%. So that actually was really great for us. We were able to decrease the number of FTEs and relocate FTEs in other areas that were necessary. What about the number of patients that came, through that same period of time? Well, you can see here that we were able to decrease the number of FTEs and the number of job positions, but we had a huge increase of 4.4% of ambulatory program visits. Also, we had an increase of ambulatory studies by 54.5%. So we had less FTEs, more efficient, adding value to patients, patient not working, not waiting, and getting what they actually were supposed to. So the other important thing is 52% of the workforce, okay, were able to be trained in different functions, and this added value for them when they actually took vacation, or when they actually, had to miss, a work due to any trouble that they had. And what about the patient's waiting time? Okay, so if we actually reduce the number of FTEs and we had an increase in the number of patients coming in for studies or consultations, how did we do with our time? So the same thing that we showed before, we don't want the patient waiting. And what we have here is an example that you can see here on the left side on the bottom that more than 800 patients came in one day. This is the 31st of August, this past month of October, past months. And what we have in green is when nobody waited more than 10 minutes. We have yellow when one patient actually waited more than 10 minutes, and this is the maximum that a patient waited. So these 104 patients, we had one of them waited 11.44 minutes, and it was the one that waited the most. And you can see that the percentage of patients that waited more than 15 minutes were zero. That's why there's no red. So it's actually great for our patients. They get what they're looking for, and they don't have to wait much. So this is the way it looks like. The patient actually punches in his ID and then gets called, and then goes to the rest of the hospital to get all the studies that he came for. So the main changes and advantages: from several cashiers to one conveniently located in the main entrance, everything processed in the main lobby except the ED, ICU, admission to wards, and central lab, like I mentioned before, better patient experience, better team performance and productivity, less patient and physicians waiting time, Better patient flow, less steps, more FTE trains in different jobs, and less variability in the process. So let's look what we did in the central lab. Actually, all the labs that we had. At the beginning, and you can see here in 2014, we looked at our map, okay, in our hospital, and what we found is that we had, two different secretaries serving four different labs, and you can see here that we had, very few sitting space. Actually, that's not even a sitting area, and we had also three different areas for blood extraction. So when we started looking at the patient journey, we saw that actually he was, if he needed, to have a blood test for cholesterol, he needed to have a blood test also for coagulation and also for knowing what type of blood he had. He needed to go through two different secretaries and have three different times blood extraction. So that was amazing to us because we've been working like that, and we didn't know, that this was actually not great for the patient because we didn't follow the patient journey. So we decided to change that. Okay, so we said, okay, the patient can't go through all these. He has to come in, get, it's the secretary reception just once. Everything that needs to be done needs to be scheduled right away. We just need one blood extraction, and then the patient goes home. So we did that, and we asked the patient if this was better, okay, the comfort with the new secretary, and 98% of the patients answered yes. If it was more convenient, okay, the blood collection area, and the 97% said yes, and was the process faster, and we had 94% of our patients saying yes. So waiting does not add value to patients. Patient delays also impacts on department, diagnosis, admissions, discharge. So adding value to patients in this way, was great for our community. And we're still looking in measuring and not asking them, if they were waiting more. So what you can see here is actually in October 17th through October 21st. Okay, so how many patients waited more than 10 minutes? And you can see only one patient, that was 0.16% of all the patients that came in that period of time waited more than 10 minutes. So it's very, very important for us that the patient actually gets, what he wants as fast as possible, what he needs actually. So more efficiency, less steps in the process, less waiting time, and better quality. These are the KPIs. We look for quality, safety, efficiency, and productivity hours at our central labs. We measure troponin. You can see here that's a blood test that is done to be able to know if the patient is having a heart attack. And our target is to have 100%, okay, in less than 40 minutes. And you can see here the maximum for that day. So it was October 21 through to 23rd. We was 24 minutes. And not only working fast, but also not making mistakes. So here is actually a measure that we have, that if we had to call a patient to come back because there was something wrong with the process of the sample, and none of them were called. So we have team huddles there. We have also worked on doing Kanbans, 5S, and also very important, the Kaizen board here is a board where all the different biochemists are able to suggest, different improvement initiatives, and the ones that are pending are on the left, the one that are in process in the middle, and the one that we have ended already are here on the right. So what about patient's discharge? Okay, very important. The patient wants to go home. Okay, nobody wants to stay at the hospital. They actually, it's not a shopping mall. So this is part of the work that we have published already at the Academy for Excellence in Healthcare from Ohio State University. And what we looked for was, when do we decide to discharge a patient? When does the administrative discharge occur? Because the data that we had before was only the administrative one. We didn't collect when did we decide to discharge the patient, or when the effective time that the patient left the room. We didn't collect that data. So when does a physician give the discharge orders to the patient? When does the patient actually leave the room? And that's what we call effective discharge. So we were measuring these four different times to look into what opportunity we had. So we evaluated the difference between when we decide until the patient leaving the room, and what happened in between. We evaluated the difference in discharge order times by different departments. And what we found was that the patient administrative discharge took place really late in the day. The process of discharge in some patients depends on the department involved. For example, orthopedics, surgery, general surgery, neurosurgery. They had different schedules, and all this variability created many different times during the days that the patient were actually leaving the hospital. And everyday admission of patients were delayed or blocked due to lack of beds. So patients that needed to come from the ED to the ICU, and from the ICU to the inwards, or from the ORs, or for surgeries, or for a cath lab, they were actually waiting in admission. So we decided to work on improving all the processes. And what you can see here is that in January through July in 2016, only 8% of our patients left before 10:30 a.m., 45% before 12:30, and 57% before 2:30 p.m. Working hard, we were able, and on all the process, not hard, actually working better on all the processes, we were able actually to increase that in numbers by 264%. So now 35% of the patient at that time, by the end of the year, were leaving before 10:30 a.m., and then 71% leaving before 12:30, and then 82% leaving before 2:30 p.m. There are some patients that actually will always leave after 2 p.m. And those are the ones that actually came in later during the day for different type of studies. So the 100% is not possible, but it was possible to push it further. So the following year, we were decided to see how can we actually target, 40% actually, less than 10:30. So more the 40% of the patient leaving earlier than 10:30 a.m., 60% 12:30, and 80% 2:30. And you can see here, this is the administrative data. We didn't have the effective time that they left the room, but we did collect the effective time after we started looking at all the processes, and we were able to shift this. So this is a histogram. This is how many patients are actually leaving, and you can see here it goes from 7 a.m. through to the midnight. You can see how it got shifted to the left. We were discharging patients faster. So for continuous improvement in 2019 and on, we decided to increase, the target. So we actually right now our target is that 50% of the patients leave earlier than 10:30 a.m. Our expectations is that 70% of the patients leave before 12:30 p.m. And also, our target is that 90% of the patients leave earlier than 2:30 p.m. And we're actually trying to reach that target. As you can see here, most of the times we are really, really close to it. So what about our surgical journey? How did we work to improve the patient's surgical journey? What we did is actually looked into all the different steps of the patients before surgery and then during the surgery. But I want to center our attention during surgery. So what you have here in the point A is when the patient is called by the OR. And point B is when the patient actually wheels in. So he actually goes into the OR. Point C is when the anesthesia starts. Point D is when the first incision is done. Point E is when the last stitch is done. Point G is where the patient OR wheels out. So the patient leaves the OR, goes into the post-acute care unit, leaves the acute care unit, and then leaves the room. So the OR area. And this gives us the opportunity, when we look into all this, to use this tool that we developed that was called patient cycle time, where we were able, with all these different steps, to track the exact time for every procedure for every different department. So what we used to analyze the data was a business intelligence platform. We actually used this to be able to look for the time since the patient is called to wheels in, the pre-anesthesia time, the induction time, how much it took us for induction, the first incision to the last stitch, so the entire procedure for the surgical part, the anesthesia recovery time, the pre-wheels out, the OR turnover time, so wheels out, wheels in of a patient, surgeon's block utilization, surgeon's out of block utilization, OR occupancy in detail, and surgeon's and anesthesia performance per surgical procedure, per procedure, and more. And what we found out was that the surgical groups without blocks, there were surgical groups without blocks assigned. Other blocks assigned were without use. There were excessive time between surgeries. Beginning of surgery sometimes were really delayed. The transfer times for patients were excessively long. Times reserved for surgical groups, were without patients. Sometimes where there were many individuals with free times, and also times where there were not enough personnel, for the procedures that we had scheduled. So we decided, as the OR committee that was created, decided to reassign the blocks as needed by surgical groups, assigning continuous block of 4 to 8 hours per team, depending on what they really needed, and then review that every 90 days. Establish the concept to book it in advance or release the block. Staff to demand and thus optimize the opening and closing time of each OR, and then assign 75% of the OR time, and leave 25% free for emergencies. And we analyzed the causes of delay of each surgery, and the objective was that the first case needed to be more than 90% on time. So by doing this, we were able to standardize the surgical preparation of the patients per procedure, the same number of staff and duplication of numbers and surgeries per month. We actually went from OR availables to 2 hours ORs opening, and we reduced the time from 7 a.m. to 10 p.m. at the beginning to 7 a.m. to 10 p.m. in those 2 hours. 1 hour was reserved for emergencies or opening if necessary, and we had the live data to analyze and perform root cause analysis for deviations. And actually, we did many more things that it's not able to cover in this presentation. So just to show you, what the major results of our lean transformation was that every patient is free. And one important concept for our hospital is that every patient is free to come to our hospital. We don't have capitation, the patient's health coverage program, we don't have that either. So the patient that selects us to come is because they really want to come to see us. So for the 12-month period from 2013, and we compare that to 2022, we can see that the number of patient ambulatory visits increased by more than 80%. Patient hospitalizations increased more than 70% without increasing any number of beds. The patient ED visits increased by 150%. And from October 2018 through October 2022, the number of employees at the hospital only increased by 6.6%. So we were able to, with our lean transformation account, only increasing 6.6% of our workforce to be able to deal with all this increase in 80% of ambulatory patients, 70% of hospitalization, and 150% of ED visits. So we have also metrics and KPIs for process quality care, and we also compare our results with different international benchmarks and ourselves over time. So just to close, our lean cultural transformation has been invaluable to us. Lean has allowed our institution not only to substantially improve on every area that adopted lean, but also to help diminish the devastating effects of inflation. Lean is an amazing driver to accomplish safe, better patient care and efficient use of resources. And hospitals do need to adopt lean culture in order to add value to patients, providers, and also the entire healthcare system, organizations, and payers. So we do believe what once Abraham Lincoln said, the best way to predict the future is to create it. And we really think that that's with lean and cultural transformation in hospitals. Thank you very much for your attention.
Oh, great presentation. Impressive. Actually, the I was looking at the comments here, and people are impressed. Thank you, Javier. Maybe I have one question to make for you. What about other processes like billing processes and administrative process or supply chain? Did you work it with that too?
Yes, that's a great question. That's a great question, actually, and more with inflation. If you're not able to work with the billing cycle in Argentina, actually, once you do your work, the next month you bill it, and then you get paid 90 days after. So imagine with this
Yeah.
inflation, if you don't actually present all the paperwork in time, you're losing 6.2% every month. So yes, we did a lot of work, and we actually found out that our billing cycles, we were missing about 15, so 15%, 15% every month. So we were able to shrink that basically to 2%. And that's usually that 2% is because sometimes you still need to wait for results. For example, if you take a biopsy. So that 2% is expected. It's very difficult to decrease it even more. But yes, we worked really hard because we were actually missing the point, of being on time with our billing cycles. So we did a lot of work, a lot of gembas. We did a lot of spaghetti diagrams for looking into opportunities, and it actually paid, really great.
Amazing. Well, thank you for your presentation. It's epic. I mean, it's incredible the work you're doing in a hospital there, and it's good that it's saving a lot of resources for sustaining the organization in such a turbulent environment and a terrible environment. You created a whole environment. Thank you for sharing. And I think it's now time to return to Thompson, back to the ship that
Yes,
he is coming.
here he comes.
Hello, guys. Javier, thank you. Thank you for sharing. Thank you, Dr. Fred. And I think great stories there.